So
Yes.
pediatric inflammatory multi system disorder, a new entity. It's new for everyone, entire world, including myself. So whatever I am going to share today is purely based on the available very scanty literature and our experience put together. I'm going to give very brief review on this. So you all know that we are suffering from the coronavirus pandemic. Coronavirus are single-stranded positive strand RNA belonging to Coronaviridae family. So it's a group of virus, because during my microbiology as well, I know about the coronavirus, but we never thought it is going to be that severe. So this is a novel type of coronavirus, a SARS-CoV-2 virus, and which has got glycoprotein spikes, and which is essentially going to bind to the ACE receptors in the lungs, intestine, myocardium, renal, and peripheral. So this is the first image of coronavirus released by China on 24th January. You can see that this is electron microscopic picture here, and the schematic diagram more or less the same, showing that a lot of spikes. The name coronavirus came because of it is appearing resemblance like a crown. So coronavirus disease is due to a SARS-CoV-2, a novel virus. That's why it is labeled as coronavirus disease 19, because December the case was reported. So at this point of time, more than 40 lakh cases are reported in the world. However, there is very less incidence in children lesser than 20 years of age group, that is children and adults and put together, which is coming less than 2.5%. This is based on the data which was available at the end of the February. So even now the data is showing that lesser than 2.5% is quite seen in most of the countries, and children are somewhat protected because of protected due to coronavirus disease. So why children are less commonly involved? Have you ever thought about that? It is a very pertinent question and important question from the pediatrician and pediatric cardiologist point of view. You have many hypotheses to discuss. One of the most important hypotheses is, in children, innate immunity is better than the adults. Probably their circulating uh, immunoglobulins are much more broader and can prevent the viral infection of any group, because in children the immune system developed very fast because of the environmental exposure to variety of viruses, and also cross reactivity with the vaccines which we give. These are all hypotheses, and nobody knows answer why children are less commonly involved with COVID-19. This is the first one of the first a serious newspaper news item came in New York Times, that is 15 children are hospitalized with mysterious illness possibly tied to COVID-19. So prior to that, there were couple of case reports either in the news, European news like Guardian, or North American news like New York Times and local, but it was not given that much attention, even the case reports from China or Italy. But people recognized over the period of time the disease which is coming, the mysterious illness coming, is very dangerous, and which has got a wide varieties of presentations. That's why people did not really understand what kind of illness is it. Is it related to the COVID-19? Still lot of questions arise in this particular category. So let us look at the scenarios which was published, which is just published in the world. All these articles ahead of printing. Still, it is not available in the journals, but with the view of public interest and also request by WHO and the CDC, these articles are available freely in the internet. You don't need to pay anything. So this is the first case scenario in the world which is published from this particular journal, Hospital Pediatrics. It's a subsidiary journal of American Academy of Pediatrics. So let us see this. They tried to link this particular case of COVID-19 and Kawasaki disease. It is quite novel from USA. So the case was like this. This is a 6 months fully immunized girl with fever, fussiness, refusal of feeds, and lab investigation showed sterile urine. And day two, it was after admission. The fever was there 5 days prior to the admission. Day two, there was erythematous rash, non-purulent blotchy rash, and day four, there was a fever with rash all over the body, the conjunctivitis present, except limbus was spared, and lymphadenopathy. The lab investigation that particular time showed increased CRP, ESR, and reduction in albumin, and there was negative for RT-PCR for COVID, and blood cultures were negative. And there was no family history of COVID in this particular child. So what is your diagnosis? Can you open the chat box? At least one or two answers I would like to know. So I am not seeing any responses neither. So anybody would like to comment? Anybody would like to tell the diagnosis? We have 135 attendants. If you don't understand the case, I can easily present it again. Am I audible? Am I audible?
Yes,
Sir,
sir.
you are
Very
audible.
clearly audible, sir.
So anybody would like to comment on this particular case? This is the first case which was reported and published in the major journal. So anybody would like to tell this? So this case story absolutely looks like Kawasaki disease. I don't have any hesitation without even doing the echocardiogram to label it as Kawasaki disease. Thanks to the family that they shared the pictures, and you can see the erythematous rash on the extremities, swelling of legs, and conjunctivitis. Limbus is spared here. So this is very typical of Kawasaki disease. We are seeing followed by seasonal flu in our country. We typically see 2 times with a lot of Kawasaki disease whenever there is a seasonal change in our country. So baby was treated very well, fit into Kawasaki criteria, and baby was given aspirin, immunoglobulins 2 gram per kg intravenously, and aspirin 20 milligram per kg. Echocardiogram was done, which was showed normal coronaries, no aneurysms, normal ventricular function. Fever was subsided, and child was planned for discharge. It was the thing. So what happened? The second sample of RT-PCR for COVID became strong positive. It was from the viral laboratory, and they actually called the doctor. They said that they again and again checked. It was positive because this was the youngest age at that particular time. A 6 months baby is having a COVID. So now, is it really an association, or is it followed by COVID, or is it an incidentally COVID associated with this disease? We have hundreds of questions in this, but however, it is very difficult to tell two different pathologies in one child. So that is the reason probably there is a link of COVID with this a presentation of a Kawasaki disease. So that's why people realize that it may not be a Kawasaki disease, it may be Kawasaki-like syndrome or pathophysiology manifestations everything mimicking like a Kawasaki. Now let us look at the case scenario 2. Now these are the series of cases from Bergamo, Italy, where the epicenter was there. Epicenter. That means the entire Europe broke from there because of the textile industries. Lot of Chinese, they work in that textile industry. After their new year in January, all these Chinese people came to Italy to this Bergamo, and then probably that was the hypothesis of the community spread. So these children, they presented with high grade fever associated with predominantly gastrointestinal symptoms, sore throat, cough, rash, and conjunctivitis. And some of the children, they were having lymphadenitis as well. So what is the diagnosis? So it is associated with gastrointestinal symptoms and also rash and conjunctivitis. These are not infants, these are little bit older children. So look at this. The Paolo Ferrare is was my fellow at Rainbow Hospital. So Paolo Ferrare from Italy, Bergamo, from epicenter exactly, he shared the case details, and actually these cases are sent for the publication. So he worked along with us at Rainbow Children Hospital last year, exactly same timing. So now you can see that the age group are 7 years, 3, 9, 7, 7, 16. So except this baby, relatively more or less all children are bigger. And gastrointestinal symptoms, except this 3 years that is younger, all it is common. And rash and lymphadenopathy and all these features are fitting into a different kind of pathophysiological mechanism. The lab investigation showed that increased CRP, procalcitonin, trop I is very high. You can see more than hundreds, even thousands here, 3,500, very, very high. D dimer values in some of the patients are very high. Fibrinogen is elevated, ferritin is elevated, transaminases are elevated, and echo function, echo ventricular function showed some of the patients are having a poor ejection fraction 25, 30, 45, and 55. Some they developed later myocardial dysfunction, pericardial effusion, coronary involvement. Lot of these problems are associated in this. So you have a case scenario where relatively bigger children, that is above 7 years, with a predominant fever and gastrointestinal symptoms, and there is involvement of myocardium, coronary artery involvement, pericardial effusion, and ventricular dysfunction. So these children were treated with IV gamma globulin, antibiotics, aspirin, and prednisolone. You can see all children received prednisolone here, all children. And they did the COVID test. It's interesting. COVID positive in 3 patients, whereas negative in 3 patients. But if you look at that, the family members, parents were parents had COVID positive, typical. So either history of COVID in the family or presence of COVID in the patient usually causing this kind of problem is the conclusion based on this. And after treatment, patients improved, the ventricular function improved, the myocarditis, Kawasaki, overlapping picture are seen in this. So they labeled it as some of the cases Kawasaki myocarditis, Kawasaki myocarditis, all confusion. So this kind of a problem arise, and this is very, very interesting. The X-ray showed that it did not show typical cases of COVID like you must have seen in the case reports that infiltrations, which is not there, whereas CT scan showed a subtle some of the information related to the infiltration and interstitial pneumonia. But ECG is giving some kind of information. If you look at the ECG carefully, there's a splintered QRS in some of the leads. So probably that suggests that a myocardial electrical conduction system damage happened in these particular patients. So I understood based on a group of patients presented in the Bergamo epicenter, Italy, showed predominant myocardial involvement. Either they present with myocarditis or Kawasaki-like picture, or combination of both is possible. Let us look at the case scenario 3. These are series of cases presented with shock treated as toxic shock syndrome in UK. This gave a lot of alarm in the world because these 8 patients were critically admitted, and this article came from Lancet. So all over the world, people started talking about this particular patient group, why this happened during the pandemic of COVID. So you have a 8 patient cohort here. Again, you can see 14 years, 8 years, 4, 13, 6, 6, 12, 8. So relatively bigger age group with a history of fever, gastrointestinal symptoms are very common in the form of diarrhea, abdominal pain, maybe due to congestive hepatomegaly, and some patients had rash, and all these patients had low blood pressure. That is very important here. Hypotension is the common finding noted in this particular patient, and all these patients responded high dose of inotropes. You can see noradrenaline, dopamine, noradrenaline. All patients essentially received a high dose of inotropes and also vasodilator therapy. These patients responded both IV gamma globulin as well as corticosteroids and antibiotics, probably a secondary antibiotics to prevent other infections, or suspicious about sepsis and all, because they presented like a septic shock. So physicians found very difficult to differentiate these categories from septic shock and ventricular dysfunction, because all patients were having ventricular dysfunction. You can see here severe biventricular, moderate biventricular, severe ventricular. So all this happened. Again, the lab investigation showed raised ferritin, D-dimer, pro-BNP, trop-T, procalcitonin, and reduction in albumin suggests that a massive inflammatory process is going on, which became evident by lab as well as clinically. So the results for COVID showed that positive in more than 50% of the cases, and more than the 50% of the cases had history of contact like a grandfather and parents. The negative patients, they checked the antibodies of IgG, which showed that there was a past evidence of COVID. So this suggests that clearly there is an insult by the virus of COVID, which is causing immune modulation in all these children and presenting like either you see some kind of dengue fever, sometimes like Kawasaki, sometimes like overlapping pictures. So now let us look at that. This is from European. So first case April 27, which was reported in UK very seriously. After that, first case in May from Royal College of Pediatrics with various symptoms. Then they actually started thinking to name this as pediatric inflammatory multi-system syndrome. That's how it name came, because it's in children, inflammation to all body, and all systems are involved, more or less 2-3 systems are involved. That's why the name came, because of the PIMS, pediatric inflammatory multi-system. TS means temporarily associated, because most of the patients, they improved very well. A syndrome usually with multiple problems will persist for a long time, whereas in this particular scenario, the syndrome is very temporarily, and which is improved with the treatment. That's why probably they thought it is an appropriate definition. However, still it is changing every day. I will show you that. So New York, again same cases reported, but they call this as MIS, that is a multi-system inflammatory disease. And May 6th, again all these cases correlated and pulled together, and which is directly correlative, either directly insult or with the history of all these things causing this kind of problem. Now let us see why COVID, this SARS-CoV-2 will cause this. What will happen coronavirus to this one, COVID-2, which has got a glycoprotein, and our respiratory endothelium, heart, kidneys, intestine, all this has got ACE2 receptors here. The glycoprotein exactly goes and attaches to that. Then what happens after that? The glycoprotein will be absorbed, RNA will be uh, will go to cells, and multiplication of this RNA will be taken place, and virus replication will happen. So SARS-CoV virus infects human through angiotensin converting enzyme to a membrane-bound protein present in vascular endothelia, cardiovascular system, renal, all these. Due to acute inflammatory response, there will be cytokine storm. The invasion of the virus to the myocardial site or respiratory leading to the hypoxemia results in oxidative stress and myocardial damage. But how this particular scenario happens, that is immediately as soon as you get the infection, those problems will happen. But in children, this is not happening. Why? They have innate immunity. The immune response to SARS-CoV-2 involves both cell mediated immunity and antibody production. So what will happen if there is a dysregulation of the immune response to of a host to an infectious agent, that will lead to hyperinflammatory response by the host. For an example, a child is having innate immunity. He has already got some antibodies because of the various other viruses which can attack the COVID virus. But unfortunately, the antibodies which are present in the child is totally insufficient to produce again immunity in that particular child, but it may be sufficient to attack the virus or prevent the virus replication in the body. So in that process, these low levels of antibodies in this child can cause antibody dependent enhancement. This antibody dependent enhancement is responsible for pediatric inflammatory multi-system syndrome. So I think this gives reasonably adequate information because of the presence of the both cell mediated immunity and enhancement of antibody dependent enhancement leads to this PAMS. The amount of innate immunity is totally insufficient. I am intentionally skipping off all these slides because my next speaker is going to talk most of these cytokine storm and how this COVID virus is going to do that, Dr. Farhan. So now if you look at, is there an association of COVID-19 and pediatric inflammatory multi-system syndrome is the major question which is burning. Yes or no? That nobody understand at this point. However, it is hypothesized that PAMS is seen as a dysregulation of the immune response to a pathogen that is late reaction to SARS-CoV-2. Like all these cases, we have seen so far, which is published, either family history of COVID present 2 to 4 weeks back prior to the child who is present in the hospital either with the Kawasaki syndrome or myocarditis or toxic shock syndrome. That indicates that this child earlier had exposure to COVID-19 and there was some innate immunity. Because of the antibody dependent enhancement, this PAMS is coming is the major hypothesis which we are going to understand today. So how it is going to cause myocardial dysfunction? This SARS-CoV direct invasion can cause myocarditis and cardiac dysfunction is a rare event. Usually it happens as soon as they get the infection and it is going to be transient along with the COVID infection, it also improves. Whereas indirect effect, whenever there is a SARS-CoV-2 is there will be demand ischemia, microvascular thrombosis, cytokine storm, all these going to indirectly act on the myocardium which causes a dysfunction. This second variety is seems to be more related to the toxic shock syndrome. However, it is impossible at this point of time to separate and tell. Probably it may be overlapping features due to acute or some kind of innate immunity. Enhancement of the antibody dependent immunity is quite possible, and I am afraid to really speak on this because we don't have much knowledge about this. So how the clinical presentation? Refractory shock, vasodilated shock in the form of toxic shock syndrome in the presence of, they can have normal or mild LV dysfunction, cardiogenic or septic shock with impaired cardiac function, Kawasaki-like illness, or most of the times combination or overlapping of this can occur. So the diagnosis is based on the prolonged fever, abdominal pain, gastrointestinal symptoms close to 60%, conjunctivitis, rash, fussiness, irritability, respiratory symptoms, and labs if you take increased CRP, procalcitonin, neutrophilia, raised D-dimer, interleukin 6, ferritin, TROP5, and myocardial enzymes, other myocardial enzymes will be increased. In this, either SARS-CoV may be positive by reverse transmitting in the family, or history of contact with COVID, or typical symptoms of COVID in the past, even in the absence of negativity of RT-PCR. So this is the going to be very essential to diagnose this condition. These are all WHO and UK definitions of this particular syndrome, which is freely available in the net as soon as you type, and you will get that. But essentially, I want to tell you, this is less than 19 years with conjunctivitis, mucopolysaccharidosis inflammation, hypertension, shock, and pericarditis, vasculitis, all these various group they are defining. Every day it is changing. That's what I observed. Last week it was totally different, and this week it is different. American definition is different, UK definition is different. But however, the pathophysiology appears more or less the same. We are just going to wait for the nomenclature of the syndrome. The first presentation is toxic shock syndrome, presents with hypertension, circulatory failure, refractory to volume resuscitation. This is very, very important. Even you give the volume, the refractory shock, that's where you may end up doing a lot of medications, inotropes, and other things. And there is no history of respiratory involvement in this. That is very important. Unlike in adults, where you see predominantly respiratory involvement, whereas in children you are seeing the gastrointestinal and other vasculitis or vasodilatory effect you are seeing. Again, echocardiogram may be normal or mild ventricular dysfunction you see. Management includes the balance between fluid resuscitation and inotropic support. This is very crucial. You have to adjust the fluids as per the requirement, and predominantly crystalloids, sometimes colloids, and inotropic support, noradrenaline and milrinone high doses they may require. And sometimes most of the papers which have shown that usage of methylprednisolone, probably we need to embark on that. Since we have got some evidence at this point of time, we can seriously think about considering methylprednisolone. And UK protocol showed ceftriaxone and clindamycin antibiotics they use. Whereas gamma globulin, it is still not established in this particular thing, because they are already having vasodilatation, lot of volume may be there, and it is doubtful at this point of time. Some patients they benefited with immunoglobulin, but still it is based on the institutional protocol and research base in that particular hospital. Second one is ventricular dysfunction and shock. Ventricular dysfunction and myocarditis like picture. Usually they present with low blood pressure and not responsive to inotropes. Sometimes if they are not responsive, probably you need to embark on new calcium sensitizers like levosimendan. And pulmonary edema is one of the major factors, so they may need mechanical ventilation. Usually echocardiogram will show ventricular dysfunction, pericardial effusion, sometimes even coronary involvement in this, as you see in case of Bergamo series, Italian series, where overlapping pictures are seen. I will show you one case of us. We are suspecting that this is a 12-year-old boy presented with shortness of breath, hypotension, managed it with inotropes, adrenaline, milrinone, and refractory to levosimendan was given. Even he was refractive, he could not tolerate vasodilators and AC inhibitors. Admission to PSU and shifted to ward, and again to PSU, again shifted to ward, again to PSU. This phenomena is still going on, and we have at this moment only some investigations which showed high levels of SGPT. TROP-I also was very high. So we clinically strongly suspected him, but dengue became positive in him. It's a very unusual to think about that. You can see the X-ray. There is a cardiomegaly and increased PVH here, and this ECG is very interesting. You can see the ECG here from V1 to V6. There are no R waves at all. That indicates that a severe myocardial damage happened. This is called as a pseudo infarct pattern. When you have pseudo infarct pattern, no R waves from V1 to V6, these are going to be poor prognostic cases, and usually the recovery from the myocardial dysfunction is going to be delayed, or we don't know the complete natural history. And also apart from that, you can see that a splintered QRS in the standard leads is suggestive of that there is a significant myocardial activity. This is one of the echo picture. You can see that ventricular dysfunction of the same patient and significant regurgitation seen here, and ventricular dysfunction suggestive. So, but COVID became negative. So I am considering that these kind of overlapping cases may come during this period and will confuse the physician. However, the main treatment is going to be more or less same. This particular category of patients, not the case which I have shown, but Bergamo Italian series, they improved very well with inotropic support, IV immunoglobulin therapy, aspirin, and antibodies. So it's somewhat clinical convince, even though we don't have knowledge about the exact mechanism of the medication, it appears that immunoglobulins play a major role in this particular scenario. The third one is Kawasaki-like syndrome. These are all typical features you also, and also they have a COVID positive in most of the cases. The treatment is going to be immunoglobulin therapy, aspirin. Some patients, they responded very well to the methylprednisolone. Refractory cases may be benefited with monoclonal antibodies. So this is the FDA approved tocilizumab, like you have infliximab. We used to give for the Kawasaki refractory Kawasaki. Similarly, this particular case presented came from India, from Chennai Kanchi Kamukkati Hospital. I am sorry, I have not shown the author's name here. They published this last week in Indian Pediatrics, which is freely available, and you can see that there is commencement of tocilizumab, and which inflammatory markers with fever, platelets did not improve. Usually platelets will go up and then come down. CRP significantly reduced. You can see that CRP was 500 to begin with, and then it came down here. So this child improved very well, and I appreciate the authors for this kind of information which they shared. So, and also remember that the Chinese data during the COVID active phase, they have given to 99 children in Wuhan itself, showed significant improvement with these monoclonal antibodies. Tocilizumab is actually recommended by FDA. It is the FDA trial drug now for the COVID purpose, and it is government regulations are removed, and which is available freely with the request. So what is confusion at this point of time? Are we going to diagnose this as a Kawasaki or Kawasaki-like illness? Are we going to tell this as a toxic shock syndrome with or without ventricular dysfunction? Is it a variant of dengue fever? So all these questions are arising, and we don't have answers at this point of time. However, the treatment is the only one which we can give, and we are just waiting for some of the results which are going to come in near future. So once lockdown 4Z is over, and you can see the people in the community are freely moving, the COVID-19 has got tendency to spread, and we are all going to get the herd immunity. During this period, probably it is going to have the peak of this pediatric inflammatory multi-organ syndrome. At this point of time in our country, it's only anecdotal case reports, or some cases are being presented and not recognized. It is quite possible. So to summarize my talk, the novel coronavirus SARS-CoV-2 affects children less commonly with milder symptoms than adults. Pediatric inflammatory multi-organ syndrome is a late manifestation of COVID-19, probably due to dysregulation of immune response to pathogen. A high degree of clinical suspicion during pandemic with supportive laboratory evidence will be useful to arrive to this diagnosis. Treatment protocols is purely based on the case-to-case basis and institutional protocols. Thank you very much for your kind attention. Now may I request my colleague Dr. Farhan Sheikh to give a talk the subsequent part of this particular session.
Dr. Palgun, regarding a case scenario which has been presented by Nageshwar Sen. So we want to know regarding the scenario 1, on which day of illness the second sample was taken.
Okay, so the physicians in USA, that is the first case from North America, they have taken with the gap of 3 days. I think the case report did not mention that, but in the original report showed that 3 to 4 days. Exact days I really don't remember, but within the 1 week they have repeated 2 samples. So first one became negative. So that's why it was diagnosed outrightly as Kawasaki disease, and gamma globulin given. Child improved very well. On the day of discharge, evening, the second report came from viral lab. That's a very important, and that viral laboratory is well reputed. Even that was mentioned in the report, and that's the reason they are actually thinking that the COVID association with the Kawasaki-like illness.
Okay, sir. Regarding a second question from Dr. Pratik Shah. So, how to differentiate Kawasaki and COVID-induced myocarditis?
I think I covered that thing. Basically, COVID-induced myocarditis usually, not always, but usually will not have a coronary involvement as prominent as we see in Kawasaki. But again, in Kawasaki's severe Kawasaki-like illnesses, also when there is a coronary involvement, there is also an involvement of myocardium, as Dr. Nageshwar showed in his presentation.
So, and another question from again Dr. Pratik Shah. So, in one of the case series presented by Nageshwar sir, so all children in the Kawasaki received methylprednisolone. But what's your opinion on steroids and when to consider it?
I think I would prefer to give steroids in this particular any kind of some kind of information, whether it is a PAMS syndrome in the form of either you have pleural effusion, pericardial effusion, some amount of myocardial dysfunction. Probably we should consider methylprednisolone, like you saw in Italian group, where all cases are age is higher for the Kawasaki disease. Usually we see Kawasaki lesser than 4 years, but here little bit older. So whenever you see late presentation with the effusions and myocardial dysfunction, not like a toxic shock syndrome.
Yeah.
Toxic shock syndrome, I think you have to take case by case individual approach. Here, I think you have this kind of phenomena with elevated CRP, procalcitonin, and D-dimer and ferritin. Probably these are the cases I would definitely prefer to give methylprednisolone.
Okay, sir. The next question is from Dr. Srinivas Mini to Farhan sir.
Yeah.
Sir, is there any evidence for COVID-19 virus less incidence in children?
Yes, that's what lots of studies are showing. First thing is, see, children can be silent carriers, but severity is definitely less in children. There's no doubt. Incidence we can't really comment because because when they don't develop symptoms, they may not be tested also.
So at this point of time, less than 2.5% is the incidence in children, especially lesser than 14 years of age group. The estimated incidence in WHO bulletin is there. Every day they are putting it. Lesser than 19 years is lesser than 2.5%.
Yes, sir. But the problem is many children are asymptomatic, so they may not be screened also. They may not be tested.
Absolutely.
Yes. So, thank you, sir. The next question. regarding the child, the adolescent boy which Naishiro sir has presented with myocarditis, whether we could do a COVID testing, antibody testing in this child.
Yes, I think it's a good question actually. This particular child, we have been discussing every day that unfortunately, because of the government regulations, we are not fulfilling the criteria to have the second sample for the COVID testing. If you want to send for second sample, you have to have institutional guidelines and the institutional scientific committee to sign for that. So probably if child improves, we may get antibody titers at this point of time, which is not available anywhere to discuss also.
Okay, sir. The next question is from Dr. Sridevi Naini. Is there any role of rotational inotropic support in myocarditis?
Farhan, would you like to answer?
No, sir. You can.
So the inotropic support in toxic shock syndrome, it should be judicious and liberal. To begin with, noradrenaline should be given in most of the cases. Whereas myocarditis presenting with shock and hypotension, again a combination of inotropes should be given to improve the BP. If the shock is refractory, if the BP is refractory or non-responsiveness to the inotropes, then probably additional medication should be added. Like general principles in myocarditis, we add calcium infusion or calcium sensitizers like levosimendan we add in case of refractory cases. I think more or less the same principles which we should follow in this particular setting. I don't think at this point of time we can differentiate whether it is COVID related myocarditis, myocardial dysfunction and treat or not is not possible because number one, diagnostic problem, number two, we don't have definitive therapeutic challenges at this point of time.
But I think the question was about rotation, whether we need to rotate the inotrope. I think that was the question. We don't do that actually when there is a shock. But I think,
Inotropic, if they develop a tachyphylaxis, probably you can change the inotropes, but most of the times this kind of a situation rotation very fast, which are not going to work out.
definitely
Dual
first.
support. Sorry.
What I was saying is in first 3-4 days in acute phase, we don't think about rotation. So maybe when the child is in prolonged cardiomyopathy, maybe on second week, this question arises. Then.
Second week, by the time tachyphylaxis and refractoriness, it's better to add another inotropes or other medications which we are suggesting.
Okay, sir. Regarding the next question to Naisha also, is there any role of remdesivir and lopinavir in PIMS?
I have seen the literature, even that European registry, whatever it is presented, there is no role of antiviral agents actually. None of the patients received because there is no definitive evidence at this point of time. Even the trials which came in NEJM also did not support even during acute infection. I don't have much experience on that. We are only reviewing the literature. Probably whoever has reviewed this particular thing, they can also educate us.
Yeah, basically, these antiviral agents are used in the acute stage of COVID-19 infection, and cardiac features, cardiac syndrome, and Kawasaki disease-like illnesses are usually presenting after 2 to 3 weeks of the acute infection. So, antiviral drugs will not be useful at that time. This is basically more of a cytokine storm. Maybe during the active COVID-19 infection, it will be useful. Like in active, a child coming with 4 or 5 days history of fever and then landing into ARDS, at that time you may use antiviral. Although the evidence is still not very strong, remdesivir is there, or lopinavir with the ritonavir combination is there. in acute stage. But after 2 to 3 weeks of infection, when you are in cytokine storm and late complications of cardiomyopathy or myocarditis, it won't be much useful.
Yeah, I think the question is if you have COVID positive during PAMS, whether should we give antiviral or not is the question. But I think it's very difficult because the
Very
population
difficult.
itself is very small. They are presenting with a different presentation like toxic shock or myocarditis. I think it's very difficult to answer these questions, to be honest with you.
Yeah. Because the COVID-19 PCR can be positive for 28 days after the first infection.
Okay, sir. Regarding the next question to Dr. Farhan Sheikh, sir, from Dr. Amir Altaf. So, how frequently it is advised to repeat PCT, CRP, and ferritin levels post IVIG and steroids to monitor response? Is there any specific guide to target fall in levels to decide laboratory response or improvement?
See, if the child is in shock and you have started IV immunoglobulins and steroids on day 1, then definitely on day 2 and day 3 you will have to monitor PCT, IL-6 and ferritin level. If you don't have IL-6, then at least ferritin level to see the response. As I showed also that there is one study which has shown that if your ferritin level falls by 15 to 20% in first 48 hours, it carries a good prognosis. So clinically, of course, you need to see fever, hemodynamic stability, and uh, other things, but you need to also see in the laboratory wise IL-6 and ferritin and PCT.
But as a general principle, CRP levels will come down after 24 hours in most of these as soon as you give gamma globulin therapy.
Yes.
Regarding the next question from Dr. Vasant Kumar to Farhan Sheikh, sir. Regarding the maximum duration of the cytosol filter, how long can be used in single session? And what is the tocilizumab protocol in respect to the IL-6 levels?
Yes. See, the problem with if you ask the company people, the cytosol manufacturers, they say you can use for 24 hours. But we have used the cytosorb in 10 patients for dengue patients with cytokine storm last year. And we have discussed these things with the adult intensivist also. And there are studies now, very recent studies, that the cytosorb filter gets saturated. It gets saturated usually between 8 to 12 hours. So and the problem is if you continue to use it, there is another problem that it may remove a lot of anti-inflammatory cytokines and that can lead to excess amount of pro-inflammatory cytokines in the body. So generally we say that use it for 6 to 8 hours, then give a break of next 16 hours, then you can repeat your procalcitonin level or IL-6 level or ferritin level. And as I said, generally also you need to look at the child, and then depending upon the response you can give one more cycle of cytosorb. Adults in adults ICU, they straight away give at least 3 to 5 cycles of cytosorb. In pediatrics, we have given some patients only one cycle and they responded, and some patients required 3 or 4 cycles also. So generally at an average you will require 2 to 3 cycles of cytosorb, each of around 8 hours, and monitor the patients. Tocilizumab also we have used, and usually you may require a second dose. Usually within first or second dose you will come to know when the fever is settling down and your inotrope requirement is coming down, liver functions are improving, then you know the patient is responding.
Okay, sir. Regarding next question to Dr. Nagesh Rao, sir. Can we predict the occurrence of PIMS as it occurs usually 2 to 4 weeks later of the illness?
Sorry, what is that? Can we detect?
Predict? Yes, sir. Can we predict the occurrence of PIMS?
Yeah.
Yes, sir.
I think we have not really come across the situation at this point of time, because if you look at the graph of COVID positive cases in our country, the peak is just touching. The case reports came from either China, Italy, Spain, UK, and USA. They reached the peak of the bell-shaped curve. While falling down, that cases or PIMS cases are coming. That clearly shows that this is an inflammatory syndrome followed by the infection which is there in the community. So I think we are going to get these number of cases maybe in June 1st or 2nd week based on the amount of infectivity our society is going to get, our community is going to get. That is our prediction. So let us not label as Kawasaki or myocarditis toxic shock. The whole idea of reviewing this paper, this seminar is to identify these cases now, and looking for these cases in the near future is very important.
Okay, sir. So, regarding next question to Naishar Rao, sir, related to the same question, whether this antibody titers, whether they are IgM or IgG positive, as the illness is occurring 2 to 4 weeks later the primary illness.
Doesn't matter.
All patients they checked IgG. IgM you may not pick up also sometimes. IgG, we'll be happy to have IgG. So that gives an rough idea about herd immunity in this society.
But it won't matter because the pathophysiology is basically cytokine storm. It doesn't matter it is IgG or IgM. See, we need to understand
Okay.
that this multi-inflammatory response syndrome is basically cytokine storm, which we are seeing from last 4-5 years in dengue. So what happens in dengue also? They are usually IgG positive after day 5, and the cytokine storm in dengue also classically happens between day 5 to day 10. So they come with the dengue fever, and initially they will only have capillary leaks, and then they respond, and then after day 5, day 6, they develop again second onset of fever. At that time, you will have IgG positive, ferritin starts rising. We see it every year nowadays. So it is basically the same thing in COVID-19 also. So it won't matter whether it is IgG or IgM, but we are seeing this myocardial syndrome and Kawasaki little very later, like after 2 to 3 weeks. In dengue, we see cytokine storm or secondary HLH right from third week, second or third week we start seeing. But this is unusual. In COVID-19, we are seeing it after 2 to 3 weeks. But essentially the thing is same, pathophysiology is same.
Now that is the reason all the studies they got the patients 2 to 4 weeks later of the COVID positivity or family history. Probably that's the reason in the studies they have mentioned IgG more common. I agree with Farhan whatever he said.
Okay, sir. Regarding the next question from Dr. KK. So, as the time of occurrence of cytokine storm is different between dengue and COVID-19, is there any particular reason for this difference?
Yeah, that's what I was saying. No, in dengue, we see cytokine storm from between day 5 to day 10, either form of a very bad storm, multi-organ dysfunction, or just a secondary HLH. Many times it happens they recover from dengue, we ship them to the ward, and then they get a second onset of fever. Gradually, liver enzymes start rising, and then we don't know what's happening. So this is usually the secondary HLH or macrophage activation syndrome, and sometimes we see they're directly going into very bad shock, which is the proper cytokine storm. In dengue, we see between 5 to 10 days. We don't know why in COVID-19 it is taking such a long time. But again, in COVID-19, the severe ARDS of COVID-19 is also manifestation of cytokine storm. The septic shock presentation of COVID-19 is also because of cytokine storm, which happens very early. It is usually between day 5 to day 10 in COVID-19 also. The myocardial involvement and Kawasaki disease-like presentation is late actually. And at least I don't know why it is so late.
Can you open the microphones to some of the people who are seniors and all in the group? They can give their opinion as well, if it is possible and allows this platform. Otherwise, okay, you carry on with your next questions. We did not prepare for that.
Yes, sir. Regarding the next question to Naishar Rao, sir, is there any role of hydroxychloroquine in pediatric patients?
Yeah, it is actually mentioned in one of the Chinese group also they studied, but these group of patients who are presenting with myocarditis or ECG abnormalities, they are somewhat a high risk for this kind of chloroquine and all. So at this point of time, there are no guidelines either or experience to suggest or show that chloroquine has got a beneficial effect. So we are not going to recommend because we don't have answer for that. So I reviewed that. There's only one paper which is showing that equivocal results are there. So that's why it's a bit hesitant to speak on chloroquine at this point of time, this kind of PAMS syndrome.
Yeah, we are talking about PMS syndrome, not COVID-19 infection, active infection.
So, thank you, sir. Regarding the next question to Dr. Farhan, sir, will there be any coagulation dysregulation in these patients? And is there any role of heparin or enoxaparin as they are used in the adult COVID patients?
Yes, yes. See, again, during an active COVID-19, lots of studies are showing there is a problem of coagulopathy, there is a problem of pulmonary vasoplasia and microthrombosis of the pulmonary blood vessels leading to VQ mismatch, and there is a role of enoxaparin. And the government hospitals in Pune, in Hyderabad, in Delhi, they are actually using enoxaparin for all adult COVID-19 patients. So if we have this kind of scenario in children, actually these things are actually not reported. But if we have, we will have to use enoxaparin. We will have to use hydroxychloroquine because adult they are in active COVID-19. They are using hydroxychloroquine and enoxaparin.
Yeah. Here, some of the cases we can give where you see superficial thrombophlebitis, or if you feel that a Kawasaki-like illness who has got a thrombotic potentiality, then it is recommended to give low molecular weight heparin also. So where you see coronary aneurysms or any evidence, it is recommended in some of the cases to give heparin. But again, it's going to be individual basis because there is no data available.
Okay, sir. Regarding the next question from Dr. Vivek B. In children with hyperferritinemia and bicytopenia, that is incomplete HLH or macrophage activation syndrome criteria, is it prudent to wait till other cytokine storm features?
Yes. See, only elevation of ferritin level is not an indication to immediately start the treatment. Many times, particularly during dengue season, we see this that they may have some elevated ferritin level. Ferritin can be 50,000, ferritin level can be 70,000. But after day 5, day 6 of dengue, if your patient is improving, there is no new fever, only there is some biocytopenia and high ferritin, but child is clinically better, child is clinically improving, then just leave the child alone, just monitor the child. Maybe every alternate day you can check ferritin levels. If you have facility of IL-6, then you can check IL-6 also, and just monitor. Only when they develop a new onset high grade fever, there is a splenomegaly, there is a liver dysfunction, coagulopathy, plus there is hyperferritinemia, then it has to be treated. You're not going to treat hyperferritinemia, you're going to treat the symptoms. And ferritin level above 5-6,000 is considered to be surrogate of elevated cytokines in the body. But only ferritin is suppose 70, we have seen ferritins of 1 lakh also. But if the patient is clinically improving, you can simply wait and watch. If there is no fever and there are no other problems, the child's there's no multi-organ dysfunction, not requiring inotropes, clinically improving, you can just shift the child to the ward and observe.
Okay, sir. Regarding the next question, sir, is there to Dr. Farhan, sir, is there any need for drug dose adjustments while on cytosol therapy by Dr. Yashaswini?
Yes, there is a chart given by the Cytosop company. You can download from the internet. Some antibiotics are removed by Cytosop. Some antibiotics are not affected at all. So you need to go through that chart, and you may have to require. Ideally, any patient who's on ECMO or on CRRT or on Cytosop, we need to do a therapeutic drug level monitoring. That is most ideal because the pharmacokinetics and dynamics are very, very variable in extracorporeal therapies. So it's very difficult to say. Some people automatically increase the dose of antibiotic because they can't monitor the drug level, but it is little dangerous. It can lead to organ injury. Ideally, we should do a therapeutic drug level monitoring when you are managing patients on CRRT or Cytosop or ECMO.
Okay, sir. Thank you, sir. These are the questions which we have taken up.
Thank you.
Thank you everyone for your active participation. We could not see you and we could not see your questions as well. Probably next webinar, if we get opportunity, we'll try to make some other participants whether they can raise the questions, and the microphone can be unmuted to them. Thank you, everyone.
Thank you so much.